Everyone is here. Everyone is already in this.
Ya. Semua ada dah?
Dah ada dah.
Yalah, boleh start lah.
Assalamualaikum warahmatullahi wabarakatuh. And good morning. I beg to Dr. Fadzil and to all my friends. So today we continue with our problem-based seminar entitled Child with Restlessness. So there will be two presenters today. So first I will present about the child with restlessness, and later on Amin will present about child with restlessness.
You kat mana ni? Teman you kat mana?
Kat rumah.
Kat rumah. Kat mana? Mana?
Dengar tak?
Mana? Tak tahu. Tak berapa suara you banyak gangguan.
Clear tak?
Clear, better. Okay.
Next slide. So this is the table of content. So I'll be discussing about the definition of the breathlessness, history taking, physical examination, investigation, and also management. So first, we look the definition of the breathlessness according to Davidson. It defined as feeling of uncomfortable need to breathe, while according to American Thoracic Society, they define breathlessness as subjective experience of breathing discomfort that is comprised of quantitatively distinct sensation that vary in intensity. Next, we go to how to approach a child with breathlessness. So basically, we need to take a thorough history taking. So in history taking, we first start with a history of presenting illness, past medical history, birth history, nutritional history, family history, and also social history. So we start first with social history. So history of presenting illness. So basically, we need to know the age of the patient, because certain age will have because certain disease, especially in the respiratory disease, will have at certain age they tend to get certain disease. Okay, and then we also need to know the onset. Is it acute onset of breathlessness or gradual onset? For example, in acute onset, aspiration, foreign body, acute exacerbation of asthma, pneumothorax, and also infection. While for gradual onset, it includes heart failure and also anemia. And then we also need to know the frequency of the breathlessness and the duration of the breathlessness, and also we need to know the timing, the timing of the breathlessness start. And then we need to assess the aggravating factor and also relieving factor. And we also need to assess the severity of the breathlessness. So in severity of the breathlessness, the component that we can assess include the patient, the breathlessness itself. Is it occur while walking or it occur at rest? Okay, and then we can also assess the patient by knowing the way he or she talk. So does she talk in sentence, phrases, word, or unable to speak? And also patient's alertness. Does she or he agitated, drowsy, or confused? And we also assess the accessory muscle usage and wheezing. Is it moderate or loud wheezing? And then we need to know the exposure. Is it exposure, for example, seat contact, upper respiratory tract infection, any exposure to allergen, or any recent travel history. Okay, next. Next slide. Okay, and then other than breathlessness, in order we want to obtain the appropriate diagnosis, we need to assess also the associated symptom. For example, noisy breathing, either wheezing or stridor. Is there any history of fever? And then cough, where either is productive cough, barking cough, or whooping cough. And then is there any feeding difficulty or drooling of saliva, any history of vomiting, choking, voice change or hoarseness of voice, any history of pale bluish discoloration, and history of chest pain and chest tightness. Okay, these are several diagnoses related with the breathlessness. So the first one is a bronchial asthma, where the associated symptoms include wheezing, chest tightness, cough, particularly at night, and also they can also present with symptom of respiratory infection. Second is a pneumonia. The common associated symptoms include fever, preceded by upper respiratory tract infection symptom, cough, lethargy, and poor feeding. And sometimes, if the severe pneumonia, they can present with not inability to drink or feeding, drowsiness, and also convulsion. And then bronchiolitis, where the patient has mild coryza, low-grade fever, and also cough. The next is acute epiglottitis, where patient have high-grade fever, cough, not able to feed or drink, and drooling of saliva. And then croup, okay, croup where usually patient will proceed with coryza and low-grade fever, and then they will manifest barking cough, stridor, and hoarseness of voice. Next is a foreign body ingestion, where patient has sudden coughing, choking, drooling of saliva, dysphagia, and also stridor. So other than respiratory causes, we need also to rule out other systemic causes. For example, in heart disease, for example, is heart failure, where patient can have poor feeding, sweating during feeding, and also poor weight gain. And also in children, they can also present with exercise intolerance, orthopnea, chest pain, and also palpitation. Next is anemia, where patient present with lethargy, pale, poor feeding, and dizziness. And lastly is anaphylaxis, where patient can have facial swelling, urticarial rash, and decreased consciousness. Okay, next. Okay, next, we need, after we taking the history of presenting illness, we proceed with a past medical history, where we need to ask about the previous episode of breathlessness, any history of admission and treatment given due to breathlessness, and we need to assess the underlying disease. For example, if the patient has a history of atopy, for example, asthma, allergic rhinitis, and also eczema, renal disease, for example, nephrotic syndrome or chronic kidney disease, heart disease, for example, is congenital heart disease, and hematological problems such as thalassemia. Okay, next, we need to assess the birth history, any congenital malformation or history of prematurity before, nutritional history, any history, any allergic to food, immunization history, does the patient has completed the immunization, and family history, especially history of atopy. And lastly is a social history. Okay, about the environmental exposure and the impact on the psychosocial aspect to the patient. Okay, after we taking a thorough history, we need to we go with a physical examination. So in general inspection, we need to look if the patient is ill looking, about the positioning of the patient. Is there any noisy breathing, wheezing or stridor, clubbing, eczema, and also chest deformity. Okay, next. Okay, next is this is a several sign of the respiratory distress. For example, nasal flaring, cyanosis, grunting, use of accessory muscle, chest retraction, and also usage of oxygen support. So in this picture, I provide you the example of flare nostril and also chest retraction. Okay, next is we need to get the vital sign of the patient. If the patient is febrile or afebrile, about the respiratory rate, does the patient has a tachypnea, the heart rate, and also the blood pressure. Does the patient is hypotensive, especially because patient with sepsis can have low blood pressure, and also in patient with life-threatening asthma can also have hypotension. And then we need to know the oxygen saturation and the anthropometric measurement if the patient have a failure to thrive. Okay, this is the about the respiratory examination. Systematically, we go one by one with inspection. So we need to look for breathing pattern and weight. Is there any chest deformity? For example, Harrison sulcus and pectus carinatum. Next is a palpation. Is there any tracheal deviation with suggestive of pneumothorax? And then reduced chest expansion. Next is a percussion. So, for example, is dull suggestive of consolidation, stony dullness, which indicate pleural effusion and hyperresonance in a chronic asthma patient. So next is auscultation. Is there any reduce of breath sound, bronchial breath sound, present of bronchial breath sound? So in patient with asthma or bronchiolitis, they can have bronchi and also crepitation with suggestive of pneumonia. So other than respiratory examination, other examination that we need to consider is cardiovascular examination, especially if we want to look for congestive heart failure sign. Okay, for example, is jugular venous distension, displaced apex beats, and also present of Gallagher rhythm on auscultation. And for abdomen, is abdominal tenderness and present of hepatomegaly. So next is investigation. So basically, the investigation done is depend on clinical suspicion. The investigation that we can do is a bedside investigation. For example, peak expiratory flow rate and also ECG. And then for full and blood investigation, full blood count, arterial blood gases, renal profile, and also septic workup if we suspect the patient has sepsis. And then imaging, especially chest radiography, to look for any abnormality, for example, consolidation, and also echocardiography if we suspect the patient has chronic heart, if the patient has heart failure. So this is the example of the chest X-ray. On the left picture, you can see there is a consolidation at the right middle lobe. And then on the left picture, this is example of the patient with heart failure presented with pulmonary edema. If you can see, there is a prominent vascular marking at the peripheral part of the chest. Okay, and also cardiomegaly. So this is example of the patient with acute epiglottitis. So if you can see on the left picture is a normal epiglottis on lateral neck chest X-ray. So the epiglottis is not swelling, but however, in patient with acute epiglottitis, they will have a swelling of the epiglottis, where it described as thumbprint sign. Okay, next is a patient with a croup, where there is a tapering of the upper trachea, and they are known as steeple sign. Okay, next we move to the last part, which is the management for patient presented with breathlessness. Okay, so first thing, we need to stabilize the patient. So we need to resuscitate the patient using the ABC. So for airway, ensure pattern airway, position of comfort, or manually do the jaw thrust or chin lift. And we need to clear the airway by using suction. And we opt for adjuncts, for example, oropharyngeal airway and also nasopharyngeal airway. Next is breathing, where we provide adequate oxygen support and we monitor oxygenation by pulse oximeter. Next is circulation, where we monitor heart rate, rhythm, and blood pressure. And we establish vascular access for fluid administration or medication. Other management include we need to treat the specific management depend on the disease. So for example, if we suspect patient have pneumonia, we give antibiotic to the patient. So other supportive management include antipyretic for fever, oxygen support, hydration status, and we need to encourage the patient to take oral intake, and we need to educate the patients and also the caregiver. So these are my references. I think that's all from me. Is there any question?
Any questions? Any questions?
Assalamualaikum doktor, I have question.
Dengar.
Assalamualaikum doktor, I have question. Dia boleh dengar tak?
Okay ha.
So I would like to ask regarding the ECG for pediatric. So in this case of shortness of breath, for example, if you do ECG, what is the finding that we would expect from the patient? Is it the same as the adult?
Tak dengar. Tak faham soalan. What expect what?
Finding daripada ECG tu.
ECG.
Yes.
ECG tak payah dah belajar.
Yeah.
ECG in pediatric complicated.
Okay.
You learn housemanship nanti. Tak galak. ECG daripada umur 1 tahun, 3 tahun, 8 tahun, 12 tahun semua berbeza. That's why I avoid teaching ECG in pediatric. Cuma basically kalau budak umur yang 12 tahun ke atas, 8 tahun ke atas, ECG dia finding sama dengan adult. Dan below than that, in early in the life, the right side of the heart is as more prominent than the left side of the heart. Then after that, slowly it reverse, and then at the certain age, at 6 years, the left side of the heart become very dominant balik. So the ECG is evolving as for the age. Nak ajar ECG dan pediatric ni kadang-kadang satu hari suntuk because it's the difference in term of ni. So you need to know dalam cardiac cause of cardiac cause for short breathless is heart failure. Mainly heart failure. Heart failure can be due to many things. Your congenital heart failure, cardiomyopathy, myocarditis, all those things. Okay. Anything else?
Dato', is there any simple way to ask about the whooping cough or barking cough in Malay?
Batuk kokol.
How we want to ask the patient regarding the cough?
Batuk lah. Batuk ada tak batuk sampai you kena imitate lah. Ada baca barking cough, batuk macam anjing. Kong ong batuk. Some parents they can you must realize dogs not in our culture, but some parents able to recognize it. For whooping cough, one thing is the coughing. They got spasm of coughing. They cough, and the face become red. At certain level, they become cough, and they take. You have to imitate in front of the parent. Easy. You go to YouTube, you have all those illustration. Everything in YouTube now, and then parent can recognize that. You have to imitate it in front of the parent. Okay, anything else?
Dato', dengar tak? Kalau patient tu ada complain of chest pain, kalau budak-budak kan, complain of chest pain. Do we have to macam tanya detail like adult punya soalan?
The most common cause of chest pain in children is costochondritis. Not heart problem.
So maksudnya cukup ke kalau kita tahu dia ada chest pain sahaja?
You can ask in detail, doesn't matter. You nak tanya the rating ke, how bad the chest is ke, progressive. It's part of the history. But to remind you, the main cause of chest pain in children is costochondritis, not the heart problem.
Okay, thank you, Dr.
Okay. Any other question? Okay, next presenter.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I am Amir and I will continue with the next presentation, which is about child with cyanosis. Okay, these are the content for my presentation. First, I will start with the definition and types of cyanosis. Then I will go into the cause, and then history, physical examination, investigation, and I will finish with the management. Okay, first, before we go further, we need to know what is cyanosis. So cyanosis is bluish purple discoloration of the tissue, which is caused by increased concentration of deoxygenated hemoglobin in the capillary bed. So there are two types of cyanosis. First one is central cyanosis.
Kejap. Nanti apa chat? Okay,
Okay, so there are two types of cyanosis. The first type is central cyanosis. Central cyanosis is a bluish discoloration that is caused by systemic arterial oxygen desaturation, and it is obvious when the deoxygenated hemoglobin level is more than 5 grams per deciliter, and this is equal to oxygen saturation 85% or less. So when a patient with a central cyanosis presented to you, so the oxygen saturation is most likely the highest is around 85%. Okay, the second type of cyanosis is peripheral cyanosis. So peripheral cyanosis is caused by the increased oxygen extraction by the tissue due to the reduced speed of blood flow in the capillary bed. Okay, so for today's presentation, I will focus more on the central cyanosis. So now we will continue with the life-threatening cause of central cyanosis. So the most common cause of cyanosis is caused by the problems in the respiratory system. So among the disease in the respiratory system, I divide it into 4 groups. Okay, the first is a disease that causing upper airway obstruction. So the first thing is a foreign body obstruction in the upper airway. So the foreign body will reduce the air intake into the lung and then cause cyanosis. And the second is infection of the upper airway, which can be either croup, epiglottitis, or bacterial tracheitis. And this infection at the upper airway, when it block or reduce the upper airway space, it can also cause cyanosis. And the next is congenital airway abnormalities and also thermal injury to the upper airway. Okay, next is primary pulmonary condition. So in severe asthma, it can, when the bronchospasm is too severe, so it can also cause cyanosis, and also in the case of cystic fibrosis. And then infection of the pulmonary system, such as bronchiolitis, pertussis, pneumonia, empyema, can also cause cyanosis, and uh, the other cause is pulmonary edema, non-cardiogenic, and also in premature infant, the most common primary pulmonary condition that cause cyanosis is hyaline membrane disease. And then next, the problems that decrease the inspired oxygen. So these are uh, in a case of house fire. So children that involved with the house fire that inhale a lot of smoke, the concentration of oxygen inhaled is reduced because majority of the air it consists of smoke. So it can also lead to cyanosis. And other than house fire, the other cause are gas toxicity. And the most common gas toxicity are carbon monoxide poisoning and cyanide poisoning. And then the fourth one is impairment of the chest wall or lung expansion. So in this kind of problem, when there is when the chest wall cannot expand, the air intake to the lung will be reduced. And this can occur in conditions such as open pneumothorax, tension pneumothorax, hemothorax, or in a flail chest, and also when there is a trauma to the chest wall. Okay, the second system that can cause cyanosis is the circulatory causes of cardiovascular system. So the most common cause of uh, cyanosis in cardiovascular system is tetralogy of Fallot. So in a newborn, the most common cause of cyanosis is cardiovascular system. However, in older children, it is caused by the respiratory system. Other than tetralogy of Fallot, the other causes can be coarctation of the aorta, hypoplastic left heart syndrome, pulmonary atresia, transposition of the great artery. Okay, the next is pulmonary edema. Pulmonary edema can be divided into two types, cardiogenic and non-cardiogenic. So in pulmonary edema, the water limit the diffusion of oxygen through the alveolar into the pulmonary capillaries and then reduce the concentration of oxygen that bind to the hemoglobin. And then the third group is pulmonary hypertension. Pulmonary hypertension can be idiopathic or causes by other diseases. And the most common secondary causes of pulmonary hypertension are left-sided heart disease and obstructive sleep apnea. And then the fourth causes are pulmonary embolism. However, it is very rare in children. And the other cause are acute chest syndrome. Acute chest syndrome is very common in sickle cell disease. In acute chest syndrome, the blood clump in the pulmonary capillary, and then it reduce the blood flow, they reduce the oxygen changes in the alveolar. And then the next one is shock, and there are two types of shock that can cause cyanosis are septic shock and cardiogenic shock. And finally, the last cause is methemoglobinemia, which is a condition where hemoglobin unable to bind to the oxygen because the ion change from F2 to F3. Ferrum 2 plus to ferrum 3 plus. And then these are the other causes of cyanosis. Basically, these are the causes of peripheral cyanosis. First one is Raynaud's phenomena. And second one is cold exposure. And third one is polycythemia. And the fourth one is cyanotic holding spells. So in order to properly manage patient that present with cyanosis, the first thing is we should ask proper history and physical examination. So the most important component in the history, the first one is age, because based on age, we can narrow our differential diagnosis. Like I said just now, in neonates, the most common condition is cyanotic congenital heart disease. And in children, the most common causes of cyanosis is respiratory problem. And then second thing, we should ask about fever. Uh, the function we ask about fever, the first one is we want to narrow down our diagnosis to infection if patient present with fever, and also if patient with complaint of fever, we want to watch out for any sign of septic shock. And then we should also ask other associated symptoms that can narrow down our diagnosis, which usually symptom of respiratory system such as cough, HOB, breathlessness, wheezing, stridor, or snoring. And then we should also ask about any prior history of trauma, and we should also ask about underlying lung disease and underlying congenital heart disease. And also in past medical history, we should ask about any history of taking amiodarone, because amiodarone can also lead to the bluish discoloration of the skin. Okay, now in physical examination, in patient with cyanosis, the first thing is we should do the general examination. We should assess whether the patient is ill or not ill, and then we look at the face, the lips, mucosa, and also the periphery. We look with for the bluish discoloration, and then we check for the skin color, because in patient with methemoglobinemia, the skin will appear a bit slate gray. And then we should also find any syndromic feature which might suggest underlying cardiovascular disease. And also we should check for any clubbing. And also assess the patient's current mental status and check for any sign of shock that warrant urgent management. And then after doing general examination, we should do detailed respiratory system examination. First, we should assess the respiratory rate, and then inspect the abnormal chest movement, check for the trachea deviation, check for the any additional breath sound, which will narrow down our diagnosis to a specific cause. And then we also need to do another system that is important is a cardiovascular examination. We should check for the heart rate and find, hear, and look out for any murmur that might suggest the underlying heart problem that causes the patient to present with cyanosis. Okay, so these are the image of child with central cyanosis and peripheral cyanosis. The left one is central cyanosis. You can see the bluish purple discoloration at the lips and the tongue. And also in the right one, you can see peripheral cyanosis, where the bluish discoloration on the hand and the foot. Okay. Okay, so investigation. The most important investigation is to check for the SpO2, because as I say, when the patient presented with cyanosis, usually the SpO2 is the highest is 85% or lower. And then if necessary, we should also do arterial blood gas investigation to check for PaO2. And usually in patient with cyanosis, the partial pressure of oxygen is usually reduced. However, if partial pressure of oxygen is normal and patient is not ill looking, so the most probable diagnosis might be methemoglobinemia, acrocyanosis, polycythemia, co-exposure or it is just a dermatologic etiologies, which means the cause is less likely from the respiratory system. However, if the patient have a normal pressure of oxygen, however, it is he or she is still looking, the cause is most likely cardiogenic or septic shock. And then we should also do full blood count to check for the focus on the white blood cell count to check for any evidence of infection, and also check for hematocrit. The reason why we check for hematocrit is because a patient with a polycythemia can also present with cyanosis. And then we can do chest x-ray to look and rule out any respiratory, any chest pathology. Also, we can do ECG and echocardiography. And then if necessary, we can check for methemoglobin level. Okay. Next, is how to manage the patient with cyanosis. So in management of patient cyanosis, it is based on the underlying causes and manage the presenting problem. If patient cyanosis that present with the respiratory distress or poor perfusion, the first thing that we should do is give supplemental oxygen. And then we also need to measure the pulse oximetry and give airway support, breathing and circulation. And then if, let's say if the patient cyanosis, and then he or she also have sign and symptom of shock, we should manage the shock. And then if sometimes patient with cyanosis also require intubation and mechanical ventilation. In this kind of patient, usually the arterial oxygen tension is decreased. However, there is no respiratory distress because the problem is in the central nervous system. Okay, and finally, in infant who have we suspect have a congenital heart defect, we should give prostaglandin E1 or alprostadil until we find the definitive diagnosis of the diagnosis, and then we manage properly based on the diagnosis. Okay, I think that's all from me.
Any questions?
I have question. What is meant by doctor-dependent congenital heart defect? Doctor-dependent congenital heart defect.
You pernah dengar PDA tak? Okay, dalam in our system, dalam badan kita, even after during delivery, dia ada right side and heart side now. Right side and left side of the circulatory system in our cardiovascular system. Cardiovascular ada heart, lepas tu ada circulatory system. So dia ada right side and left side now. So in you see like the example TGA, transposition grade aorta. Transposition grade aorta with transpose saja, what happens is that during delivery, during physiological changes, the right side and left side didn't mix together. The left side and right side didn't mix together, and the baby going to die because during intrauterine, oxygen come from the umbilical placenta or umbilical vein, but in the post-delivery, oxygen come from the lung. Okay? If the right side and left side, the right side function is to oxygenize the blood, and then the left side function is to bring the blood, oxygenized blood to hold over the body. So if there is no mixing between these two, like in TGA, transposition grade aorta, patient going to die. So during delivery, at the first few days of life, there is a ductus, they call it ductus, ductus arteriosus, that connect between the right side and the left side of the pulmonary vein to the arch of aortic. They got a valve, they got a ductus there, ductus arteriosus. So if the ductus is closed by that time, in disease that TGA, baby going to die because there's no mixing of blood. So there's no oxygenation blood sent to the body, to the whole or to the body tissues. So because of the certain disease at TGA, the ductus persist. They didn't close. The ductus persist, and then we have to make the ductus to persist by how we give the prostaglandin. We prevent the ductus to close. If the ductus is closed, baby going to die. Okay. Okay, that's all you. Baca lah. You have to read. Ductus dependent. That will explain better, illustrate better inside your internet. You Google saja, there is a explanation there. Just Google. Dia ada gambar, because if I talk like this, you won't able to visualize it, because firstly you didn't understand how the cardiovascular system in intrauterine, post-uterine. It's going to be a long discussion. So this basically is that, but please open the internet, Google it, ductus dependent, and they will explain to you in nice diagram. Okay, any other questions? Okay, I like to remind you all, most of the information you want to know about knowledge is you can Google it, not a problem. Not a problem. You see, we would like you to ask more to us about clinical, clinical things, not knowledge things. For me, who ask me about knowledge things, lazy. That's all. Lazy want to do the search. To do the search, because you just everything you want to know the metahemoglobin. Very easy. You just Google it, it's inside already. A long explanation, please, nice. You want to know about the whooping cough, the whoop. You just Google it, YouTube it, and you dapat the whooping cough. Nice diagram, nice audio visual some more. You want to see about the pertussis. Whooping cough lah. Or you want to see about the question just now, difference between the whooping cough and the pertussis, is it?
Yes.
Somebody ask the questions.
Yes, Doctor.
Whooping cough. Okay, whooping cough and pertussis. Actually, whooping cough and pertussis. Whooping cough and pertussis nearly the same. Sorry, the one talking about the barking cough is the croup. The barking cough will be the croup. Croup will be the barking cough. Whooping cough and pertussis is the same. But this is the kind of question you just can Google it. You can Google it. What is whooping cough? It is a definition, layman definition for pertussis. Whoop, because the child have coughing and they're unable to inspire, because of episode of coughing, they whoop. That is whooping cough with pertussis. Croup is different. Croup is because of the subglottic inflammation resulting in the barking cough. Okay, that is the different. And then the question I like is, I don't know about you can ask more of clinical questions. presentations, how to do presentations, test about, okay, you're talking about cyanosis, in terms of the common presentation, how cyanosis, compare to, how you want to differentiate cyanosis due to respiratory and cyanosis due to cardiac clinically. Example, that is the kind of question I like, because that is the question that I have to explain to you in terms of clinical, in which you don't see much in the book or Google. If you ask me about how does the cyanosis occur in congenital cardiac disease, then I will say to you, just Google it. You Google it and you read it. So you tell me that, do you use your searching for knowledge properly or not? Because nowadays the knowledge is at your tip of finger. Unlike us last time, we have to use the book. We have to bring the book everywhere, find the book, baca buku, page mana to find, even to find out. Now you can Google it very fast, and you all must know how to Google to get the knowledge now. What is the keywords? What is the need? What is to get the? You have to know which is the best website. Give you the best information in Google. The second thing is about the presentation. I think it's okay. Now you go to clinical, but there are the way of thinking process. So when all patients come with shortness of breath, all the patient come with shortness of breath, cyanosis, all these are symptoms. This is the chief complaint. This is the reason why the patient come to see you. Chief complaints. The reason the patient come to see you. So the next thing come to your mind is that when there is a symptoms or chief complaint, like shortness of breath, wheezing, cyanosis, the next thing come to mind to list down to your brain is, what is the cause? What is the cause? You already list down in your brain. Then after that, you start to ask questions, HOPI. When you ask the questions, then the basis of the questions the base of your question inside your brain is that you ask about the is it acute or chronic? When is it happen? Why it happened? What's the cause? How severe is it? And then you look for the associated symptoms to indicate to you which system involved. Then you go after that your other histories, and then your physical examination. Physical examination is the same to find the causes and severity. So physical examination is how you present. Physical examination also very important. If your history decide that your history give you the clue respiratory is the main problem, then you start with respiratory system. If history to give you a clue is cardiovascular system, so you start with the cardiovascular system. Then after that, you make your diagnosis, a differential diagnosis. You argue on that, what is the diagnosis, what is the differential diagnosis. Then you do your investigation. Your investigation based on to confirm your diagnosis and to exclude your differential. Then after that, you go your management based on the cause and severity. That is the clinical thinking that we want you to have. So that is the PBS all about. So the presentation have to mix up all those things. Start with chief complaint, possible causes, and then the HOPI, how you integrate the possible causes inside your HOPI, and how severe is it, and then you proceed after that to complete your clinical situation until you have your diagnosis and then your management. That is how the doctor thinks. The training for your 5 years to think like this. You see, the books only take a small part only. The books only come at the courses. The courses. What is the courses? And though the book tell you about the clinical condition of each courses, it is your skill to extract the information from the patient and parents, and it's your skill try to critical thinking about the signs and symptoms and to get the causes. How is it your brain think critically to decide the causes? How severe is it? That is your skill that you can only get by training and exposure. So sadly, because of COVID, we cannot utilize, maximize your training. So you have to find a way. You have to find a way to simulate your brain, when you handle any patient. Any questions? Any questions? Ada lagi tak PBS with me? You have the PBS with me?
Next week we only have a teaching seminar with you.
Seminar boring. When your seminar boring? Seminar just PBS is where your clinical skill tested. When you will come back? Tak tahu lagi.
Tak tahu lagi.
Tak tahu lagi.
Yeah. There are possibility to extend your punya ni.
For example,
because we are worried about you don't have enough face-to-face training. Tapi you kalau duduk kat sini you asrama semua you kena bayar tak? You still have to pay.
Kena bayar.
You walaupun you duduk kat rumah. Kena bayar.
Kena bayar yuran.
You asrama kena bayar juga. You asrama tu termasuk makan sekali lah. Tak?
Tak.
Penginapan je lah. Just save makan je lah. Duduk makan kat rumah je lah.
Save dan lagi sedap. Save duit dan lagi sedap makan kat rumah.
Mana lebih mahal? You punya makan ke you anak asrama?
Kan.
Makan. You roughly habis satu hari berapa ringgit makan? $50.
10 to 15.
10 to 15. 10 to 15, you 750, roughly 500 to 1,000 dah habis makan dia. Dahsyat you all ni. 500 ke 1,000 untuk makan saja. Sebulan. Dan 300, 500, okay, 300 ke 500 okey lah. 30 10 to 15 time to 300 to 450. Okay lah, 500 okay lah. Not so bad lah. Tak apalah, we are still thinking how to optimize your learning process before you become housemanship. Tak tahu macam mana nak buat, sebab things keep changing. You dah cucuk belum? Ada dah cucuk?
Tak ada.
Ada.
Ada lagi?
Baru nak daftar petang ni.
Eh? Ada yang cucuk lagi?
Tak ada.
Oh, ada 6 Jun cucuk ya.
Untungnya.
You dapat apa? Astra punya AZ punya ke ataupun
Saya dapat
Pfizer?
AZ.
Tak tahu lagi.
Saya dapat AZ.
AZ. Okay lah, AZ proven that reduce the cost, reduce the incident at UK. Tapi cuma AZ didn't cover well the South African punya ni variant. But otherwise, it proven even the AZ cover quite well. Even the latest one, the Indian variant, they cover quite well. We worry more Indian variant though because ada double mutation. Apa? Okay. Yang lain ada siapa ni tak nak cucuk? Ada siapa sini tak nak cucuk? Kita semua cucuk tak ada apa. Semua okey cucuk, orang tua cucuk tak ada apa semua. Okay, that's all. We see how it goes because I think we still need face to face with you all, especially the clinical teaching. Tak apalah. Okay, anything else there? Okay. Besok ada group ni kan. Okay, about the clinical case discussion tu. Nantilah fikir dulu macam mana. How many clinical case discussion I have with you all?
Setakat ni only one.
Only one lah. If let's say you are unable to come face to face for whatever reason, because you're 7 week kan, this is your second week kan, third week or second week, and then I may have to ask you all divide to 3 groups, and I will take 1 group each. 1 group each. Maybe I have to divide 3 group, you all, then I take 1 group each, 1 case like that. Okay, because I don't know how to teach clinical with 28 people in front of me. I don't know. Susah nak marah. 20 orang nak marah macam mana susah. Susah nak berhenti. Okay, Okay, finish now.
Doktor, so yang case discussion tu tunggu nanti face to
Tunggu
face
dulu,
lah.
if I have to discuss, tengok dulu macam mana how the progress. If not, I may inform you all. If you proceed, then you have to that I did for year 3. I ask them to divide to 3 group, and I take each group one at different time. Okay. Okay. Okay.
Yang untuk procedure presentation ni so pukul 12
12. Kalau tak busy lah, I got clinic tomorrow. But now 50% actually dengkam. Okay.